Thank you very much. I was invited to speak at this really fun seminar about how to prevent getting a stroke. And I think many of you know what a stroke is. Several of you know people who have had a stroke, and some of you may have had one. And I wanted to really begin by talking about really what is a stroke, how does it manifest in our society, and why is it such a big medical problem? But more importantly, instead of focusing on, gee, this is a really serious disease, I really wanted to spend more time about the prevention. So what I want to do is to really, I'll even cut myself off if I'm talking too long, because I want to give it adequate time for you all to ask questions, because I think the questions that you'll ask will be much better than any didactic presentation. And I think a question you may have, other people are probably interested in hearing the answer to this. So I wanted to just though show you some recent Centers for Disease Control statistics. These are 2013 data that's showing that I was looking at my presentation from 2011, and in 2011, stroke was the third leading cause of death in the United States by medical cause. It's now fifth. It's pretty interesting. And that's not because the other diseases have gotten more prevalent here in this list. It's actually because we're doing a really good job of preventing stroke. And our stroke treatments have actually improved as well, so as we'll talk about. But still, it's an enormous problem. Vascular disease is the chief risk factor for this. So many of you know the risk factors for developing a heart attack, coronary disease. As we'll talk about, many of these are quite similar. If you look at the world burden, though, of stroke, it's the second leading cause of death worldwide. Unbelievable. So if we think about patients in China or in India where hypertension is relatively untreated, these are the #1 causes in those countries. And just preventative strategies of treating high blood pressure, hypertension, can actually lead to a reduction in mortality. So as a world health problem, this is of an enormous magnitude. In the United States, about 800,000 people in our population have a stroke each year. That turns out to 1 every 4 minutes. In San Francisco County, which you're in right now, we have 9 receiving hospitals. There are 2 strokes a day in our city. Some of these can be treated and some can't. If you look at the burden of people who have had a stroke and are starting to recover from it, at any one time, there's about 1/3 of a million people who are disabled from stroke requiring services. And that leads to about 3 million stroke survivors. So many are completely back to normal. So although maybe 10% of them are disabled at any one time, most people do quite well with this. And I think that's a testament to how the brain recovers. Now later on this afternoon, Adam Gazzelli is going to come and talk about ways you can remap the brain to take over functions that might have been lost. And so we'll talk about stroke as a disease of the brain, rarely of the spinal cord, but mostly of the brain. And if a part of it is damaged, how can you use other areas of the brain, reprogram them to do things that you've lost? And some of the work that he's doing is absolutely outstanding, and I'm sure you will enjoy that talk. It's very regionally specific, too, in the United States. So this color map from CDC shows the prevalence of stroke across the United States and regions. And if you'll see, the darker the color, the higher the number of strokes per year. Here we are over here in the far west, we're pretty much in these very low ranges of 13 to 72.7 per 100,000 population. But if you look at the stroke belt, which is the deep south across the southern part of the United States, the amount of stroke is incredibly high. And so a lot of the disease is actually focused in that area. A lot of that is because of untreated hypertension. It's also because of obesity. Our body mass index in Marin County and its surrounding San Francisco area is among the lowest in the nation. And interesting, our longevity is among the longest of any county in the nation. Because, in part, we think the health of the individual, keeping their body trim, and I really am going to work on this, I'm telling you. So I was preparing for this lecture going, they're not going to listen to a fat guy, are they? It is continuous effort to keep body mass low. And those of you who struggle with it know But it is incredibly important that we work on this. And I think that correlates. It's not just body mass index that makes the difference here, but it's a strong correlate because it reduces diabetes, and diabetes is a bad actor. The cost of stroke is, at current estimates, it's about $34 billion a year. Some of this is in lost work and productivity. Some of it's in the medical care associated with the treatment. So a lot of this, though, is in the costs of actually tertiary quaternary areas to take care of a patient, whether it be nursing home costs, rehab medicine, et cetera. I want to just talk more about really what stroke is so that we've got a concept of how to prevent it. And the definition of stroke, a neurologist, as I am, would say it's usually the sudden onset of neurologic symptoms that can be explained by a vascular cause. Okay, yeah, what does that mean? So really what we're saying is it's a clinical phenomenon where a patient is fine 1 minute, the next they have some neurologic deficit, like can't move half their body, can't see, can't speak. And I can explain that because there's a blood clot that's stuck in a vessel in the brain, or there's been bleeding into the brain itself, a primary hemorrhage. And I can tell that based upon imaging as well as my clinical exam. And it lasts more than 24 hours, and sometimes permanently, but usually gets better. It's a TIA, a transient ischemic attack, if it lasts less than 24 hours. And a TIA really lasts typically 10 to 15 minutes. So the right side of your body goes weak for 15 minutes and then recovers completely. What do you think most patients would do in that setting? Most of them go back to bed and say, yeah, well, my diabetes is out of control, whatever. That, we know, is a risk factor for stroke to come. It's the harbinger of something to happen. And so one of the things I want to leave you with is these warning signs that if one of these things happens to you, I want you to get immediate medical care because we can do things to prevent a stroke that could happen in the next hours or days. Usually, as I said, 85% of strokes are due to loss of blood flow to the brain, and the other 15% are actually due to bleeding inside the brain itself. We call this a brain attack. It makes sense, like a heart attack. This is a brain attack. We use this medically as a term. We use it as a way to expedite the care and treatment inside the hospital. What are some of the symptoms? Well, your cerebral cortex is organized so that you have what we call the homunculus, the way that the body is laid out over the cortex. A lot of the cortex is responsible for face and hand movements because those are the eloquent things that you do on a daily basis, and very little for trunk. An injury to this part of the brain would cause weakness or numbness of the opposite side of the body. The weakness can be severe or it can be minor, but it's usually a sudden onset. That is one of the stroke or TIA symptoms. You might have the sudden inability to walk, or you lose your balance or have a sudden spinning sensation. That can be due to the balance centers of the brain, the posterior part of the brain, the cerebellum and brain stem, being injured or have blood flow problems. You might have trouble speaking or comprehending. Now, this is not the selective attention to your wife, right, guys? This is where you actually do not understand. You can hear that there's sounds coming out of my mouth, but it just doesn't make any sense. I could be speaking a foreign language, and you wouldn't even appreciate it that it's language. Or the opposite is you can't think of the word to say, you can't name things, you can't complete a sentence, and it's persistent. It goes on for minutes to hours. It's not one of these can't think of the word I want to say kind of things. It's the inability to come up with any words to speak. That's aphasia, a problem with language, and that lives in the left hemisphere of the brain. It's particularly vulnerable because a lot of the blood flow to the brain goes to that region, so it's easy for it to be blocked. You can have trouble where you lose vision in one eye, just like a shade being pulled down, that the whole upper part of vision in one eye disappears painlessly, and then 2 minutes later, the shade goes back up. Totally painless. Or you have trouble with double vision because your eyes aren't yoked together, so one eye is going out while one eye is going forward, and that would give you a double image, and it's very noticeable and disconcerting. May last 10, 15 minutes and then clear. That's a TIA. And lastly, if you have an aneurysm in the brain or other vascular abnormality that ruptures and bleeds into the brain, it'll cause a sudden, very severe headache. Probably everybody here has experienced a head pain sometime in their life. What we're talking about with this type of headache is it's as if somebody hit you in the head with a baseball bat. Just like that. It's that severe, that sudden. Often you're propelled, knocked to the ground, and then you look around as if somebody hit you and there's nobody standing near you. That's the type of headache I'm talking about. Headaches that come on slowly over time or build over hours typically are not related to any bleeding in the brain. It's a sudden onset severe headache. Those are the main symptoms of stroke, and why, as I've been talking about, these are problems with blood flow to the brain, either that the blood itself has stopped flowing or the blood has escaped from vessels. And the brain itself is highly, highly vascular. There's several blood vessels that come up the front of the neck and some up the back that control all of the brain blood flow in the brain stem. Blockage of any particular artery can cause symptoms. Here's your heart, your aorta coming out of it, aortic valve, two major arteries going up to the anterior part of the brain, the carotid arteries. This location right at the neck, which is right where your Adam's apple is off the side, that's the carotid bifurcation. It's the bifurcation because it's the common carotid artery that comes up, producing an internal and an external artery. The internal goes to the brain, and it is a location for disease, specifically in people who are hypertensive, smokers, diabetic patients, some people with positive family histories as well. That disease itself can produce a plaque or narrowing that can go up to the brain and block a vessel in the brain. So, for example, how does this happen over time? Well, you know about coronary atherosclerosis probably, where there's hardening of the arteries. There's an injury to the endothelium of the blood vessel. Inflammatory cells called monocytes come, bind to that. That brings in a fair amount of lipid, and the lipid is in the form of cholesterol that you have circulating in your body, which is a normal substance. That gets imbibed into the bottom of this plaque, raising the inner surface of the blood vessel up. And then, for reasons that we're not quite sure, after these smooth muscle cells have crawled in and kind of roofed this thing over, there can be a rupture in this plaque, and that'll attract platelets, one of your blood clotting factors. And those platelets, when they attack, they may just come and dissolve and no one would be the wiser, or they may break off and actually produce a blood vessel blockage. So when that thrombus, or the collection of platelets, forms, that blood clot can break off in what we call embolize, for Latin for travel, up into the brain, blocking blood flow. So the primary problem here is the atheroma inside the vessel wall, and the cause of the actual thrombus formation are platelets and other clotting factors that come together. The reason why we use aspirin, or Plavix, or other drugs like that, or even anticoagulants, is to prevent the thrombus from ever forming in the first place and going to the brain. However, we want to take a step further back and say, let's get rid of the atheroma that's here as well by dietary treatments, keeping cholesterol low, exercising, not smoking, okay? So one of the principal causes of stroke is from the carotid artery. In the city and county of San Francisco and in the surrounding areas, we don't see anywhere near the amount of carotid disease that is seen in the South. We think that's dietary influence, we think it's body mass related, and we think it's related to the incidence of smoking, which smoking is, dramatically dropped. If you want to see a severe form of this, this is actually the inside of an artery that's taken from a patient with severe atherosclerosis. The vessels should look pristine. They should be able to be almost translucent. And this one's covered with cholesterol and lipid, fat, and smooth muscle cells. The other cause that I wanted to talk about because of its prevention is atrial fibrillation. Some of you may have that. Some of you may know somebody who has it. It is mostly a silent, abnormal rhythm of the heart, where the heart is not beating regularly. So normally, your heart beats like a good metronome, right? 60 beats per minute, 70 beats per minute, and the beating sounds. Okay, nice and even. A person with atrial fibrillation has an irregularly irregular heartbeat. Sounds like. One beat to the next doesn't predict the next one. They're totally irregular. It's a chaotic contraction. That we know predisposes, this is me actually when I was younger. The problem, the pathology of this is that the atrium, which controls the rate of the heart, controls and sends a signal to the ventricle to contract, is beating at a very high frequency. It's usually because it's stretched. Clots can form inside that, go into the left ventricle, and ballistically be brought up to the brain right where it plugs a major vessel. The clots that come from atrial fibrillation tend to be very large, and so they tend to block very large vessels of the brain, and the mortality from these strokes is extremely high, in some cases over 75%. Now the cool thing about this is that if you have a fib, or you have intermittent atrial fibrillation, where the heart goes in and out of that rhythm, it is entirely preventable by taking blood thinners. Now by blood thinners, I don't mean aspirin, things that work in the platelets. I'm talking about drugs which prevent clotting. And those are drugs like warfarin, and there's a whole new set of these drugs out, like apixaban and rivaroxaban and something elseaban and all of that. A whole bunch of new drugs that have come, which are actually far safer than some of the older drugs that we've used. And so one of the teaching points of this is that if you have a fib, or if you've been told you've had a fib, and you're not on a blood thinner, you need to justify why you are not. Some people can't tolerate them. Some people are scared of them, and that's one thing I'd like to get you away from. And others just don't know about them, and that's part of the purpose of this discussion. And we'll direct some more of our attention to that. We know that if the blood flow to the brain is reduced to low levels for a certain period of time, your neurons inside the brain will either live or die. If the blood flow was reduced a tiny bit, you wouldn't even know that anything happened to you if a blood clot went up to the brain and then dissolved and went away by itself. If, however, the blood flow comes down to a level that turns off nerve cells, you might develop one-sided weakness of the body that lasts 10, 15 minutes or an hour, and then it totally recovers on its own. That's a TIA. A stroke is when the blood flow comes down so low that it crosses this line of what we call infarction, where tissue actually dies, and that is a very time-sensitive function. The lower the blood flow and the longer it lasts, the more likely that cells in the brain are going to end up with this fate. So another point of this is that means that if we could restore blood flow to your brain in the case of an ischemic infarct, we can actually reverse it and save the brain from damage. And there's two ways to do this, but first we need to know if you're having a stroke, do you have bleeding in the brain or do you have ischemia, just low blood flow? And the way to tell from that is by doing emergency imaging. You can use an MRI scanner or a CT scanner. Every city emergency room in the city and county of San Francisco have this technology. There are several of them that are also considered primary stroke centers that treat stroke as an emergency. And there are others that treat it as a comprehensive stroke center, which I'll get to in a moment. But the goal is first to image the brain rapidly, and then we can do other things to look at the blood vessels of the brain to tell if they're blocked. This is an image from a patient who is actually having a stroke. And you can see the detail of anatomy we can see in the individual person in terms of all of the bones, spine. We can tell all of the blood vessels that are running to the patient's brain. Here, these are the intracranial blood vessels on the particular patient, the vessels within the head and neck, and also up to the face, basically everything. This takes us 15 seconds to acquire. And from that, we can get a pretty good idea of which blood vessel in the brain is blocked. If we think the person is having a stroke, we can administer a drug by vein, a drug called tissue plasminogen activator, that breaks up those thrombuses. So that thrombus that's formed dissolves down and goes away and prevents further clots going to the brain, but also dissolves the clot that's blocking the blood vessel in the brain. That works for many people. It has to be given within 4.5 hours. For every minute you wait not giving it, you lose 1 day of disability-free life. For every minute we wait for larger strokes, a patient loses between 1 and 2 million nerve cells in the brain. So it behooves us as medical professionals to act very quickly. So if you had a stroke and the paramedic brings you to the hospital, we rapidly do a brain scan, and if TPA, this drug can be administered to you, start it as soon as possible. And in many cases, we don't take time to consent you. We do it because some of you are not in the stage actually that you can even understand consent. If you're having trouble with language, you can't understand the instructions we're giving you. We don't want to spend a lot of time saying, okay, this is the risk and this is the treatment, when your brain is dying in front of us. So we treat. Now there's another form of stroke that's even more severe, and these are strokes that affect the large blood vessels of the brain, the vessels that you can see. They have names to them all. This is a particular case of a young gentleman who had a tear in one of the arteries in his neck, and it shot up a blood clot to this artery at the top. We call it the top of the basilar. This is a highly magnified view of his basilar artery, and there's a clot right here you can kind of see because this blood column stops at that point. This is 85% fatal left untreated. This is a healthy guy, 31 at the time. I was involved in research that got this device approved as the first device to treat stroke. It's basically a little corkscrew and a catheter. That's the clot that was inside his brain in that small section, and this is what his blood vessel looked like afterwards. Totally recovered, back to work, and is doing well today. He's now in his 40s. The idea here is simple plumbing. You've got a big pipe that's suddenly blocked. Can we go in with a catheter? And the way these catheters go in is they go in from the groin. We go all the way up through the abdominal aorta, through the aortic arch, up the blood vessels of the neck, and into the clot itself. Screw this corkscrew device in and pull it out. When we first presented this data, which was in 1993 to the Food and Drug Administration, they approved this device for use in humans. We didn't prove that it actually helped patients necessarily. We proved that we could open vessels. And about 10 years of very aggressive research pursued, but in the beginning of this year, in 2015, some newer devices that are better than this were tested, and they have now been proven so effective that there were 7 trials that ended. Many of the trials ended early because it was unethical to continue. It was so effective. So we now have a treatment for these strokes that take a person with an 85% mortality and have them walk out of the hospital. Holy cow. And just as a statement about UCSF, that research was in part done at UCSF. It was done in collaboration with many stroke neurologists throughout the world. But if I did not have the opportunity to work at UCSF and given the chance to do that type of work, perhaps it could have been delayed. I'm not that important a guy, right? I was just at the right place at the right time to really advance something. And we now have a treatment that changed the practice of stroke in the entire world as of last January. It's pretty cool. And now it's California Pacific Medical Center has one of our trainees, Joey English, who's expert at this. We have 7 people at UCSF, at the VA, at San Francisco General, at Moffitt Hospital that do this. Kaiser Redwood City does these treatments. More and more, we're seeing more and more hospitals take this on. So it is a revolution in benefit. But okay, that's fun in terms of the technology and that kind of stuff. But what I really want is to go out of business, right? I don't want you to have a stroke in the first place. I want you to prevent it. I don't want to ever have to bring you into the hospital in an urgent situation and hopefully help the brain. Because still a lot of people, even despite these treatments, don't do well. And we need to do it sooner and faster and earlier, and that's something that we're working on very aggressively. But the question is, how do you prevent it in the first place? Well, there's certain things you cannot change. Unfortunately, we can't change our age, and I think that's a big focus here. Actually, I like getting older, by the way. That's all I can say. If I knew what I knew now and went back to college, oh man. Gender, interestingly, is a factor because although men are at higher risk of coronary disease and heart attack, women are more likely to die of a stroke than a man. Isn't that weird? And I think it's because some of the men don't survive to have a stroke later on in life. That's part of it. But the other is that women, once you go through menopause, your vessels age faster because you don't have the influence of the testosterone, the low testosterone influence that you had when you were younger. So you develop atherosclerosis faster, and women also get atrial fibrillation too. So it's a surprising statistic that it's a higher risk for women. So it's breast cancer and then stroke. Okay, in men it's coronary disease, et cetera, and stroke is down lower. And then certain ethnicity predisposes for stroke, both from genetic factors as well as socioeconomic status, so that Caucasians tend to have the lowest rates of stroke. Certainly if you're high socioeconomic status, Caucasian, you have the lowest incidence in the United States. If you're African American or Hispanic in the United States, your risk may be twice or 3 times as high, depending upon preventative health care. And so there are a lot of issues related to race that are big issues in the United States, topical in the news in many ways now for disparities in care that can be fixed. You can't modify your race, but you can modify your risk factors. So factors that are really under your control is hypertension. High blood pressure is the #1 cause of stroke, and if you treat your blood pressure, you can cut your risk of stroke in half. It's pretty cool. It's something you can measure yourself. You've already been harped on about blood pressure and all that. Well, this is something that's entirely in your control. If you do not own a blood pressure cuff, you should buy one. If you are young and don't have hypertension, you need to buy a blood pressure cuff to put it on your parents. Buy blood pressure cuffs. I don't have any stock in blood pressure cuff companies, but I wish I had. You need to measure your own blood pressure. It's not okay to go to your doctor once a year, even though that's the standard recommendations of measuring your blood pressures once a year, have it checked. Check yours somewhat frequently. The way you check your pressure is seated in a chair for 5 minutes before you push the go button, okay? If you walk into the room and you sit down, you find a cuff and you put it on and you hit go, your pressure is going to be higher than if you repeat it in a few minutes, right? You've all done this on yourself, right? You notice that your pressure comes down with a little bit. Rest for 4 or 5 minutes before you measure it. Measuring it in the morning, measuring it in the evening. I'm not saying you need to do this every day. I want you to do this on occasion so you know that on occasion your blood pressure is fine. Your systolic pressure should be less than 130. At all times, really. Not during exercise, not during stress, but during resting state. Once it gets above 130, we call that pre-hypertension. Once it's above 140, it's hypertension. Once it's above 150, we're saying, and once it's 160, 170, 180, 190, one of our patients just came into clinic, was 207 systolic. She felt fine, had no symptoms at all, but that was her blood pressure. That we know for every millimeter of mercury you're above 130, your risk of stroke goes up, as does heart disease, okay? So measuring blood pressure is key. Virtually nobody smokes here. How are we doing on time? Okay, great. Nobody smokes in this room, I'm sure. It's a non-smoking room. Ha. I quit smoking and I've done it 1,000 times, yeah. We have some among the lowest cigarette smoking rates in the nation in California. Some of that's related to the laws, some of that's related to very aggressive campaigns. It is among the most addictive substance that is available on the market right now. It is very hard to quit if you smoke. I've done it. I did it when I was in college. I smoked. Do you know how I quit smoking? Ha! I started chewing tobacco. It's a perfect alternate addiction because I was getting the nicotine but not the smoke. Yeah, gee, that's pretty healthy. Do you know how I quit chewing tobacco? I met my wife. That was the end of that. And I haven't, but I can tell you that I did not stop craving nicotine for 5 years. And that's the problem with addiction. We now know actually how addiction forms in the brain. There's a group of cells that are right behind your nose. They're called the nucleus accumbens. They're a group of nerve cells that if they are active at the time you're opposed to a drug or a behavior or an event that's addictive, it will stick into your body, it just gets memorialized. If you take those cells out of the brain in animals, they can't get addicted. They won't get addicted to cocaine, alcohol, all kinds of different things we can test in the lab. And there are certain examples in humans where that's been the case, where they cannot become newly addicted. The problem with it is that you can't go into that part of the brain, turn it off, and lose an addiction. Once you've got the addiction, it moves elsewhere. But we now know how addiction starts. So the only way around nicotine is to actually stop, and you really have to be completely away from it for a number of years. And there are ways to do that. There are some medications that can help, but it's mostly behavioral. The impact on health is dramatic if smoking is stopped. Heart disease in general is pretty much the same disease as we have with stroke. It's related to diabetes, hypertension, smoking, and preventable in the same ways. Alcohol intake, how much is too much? No alcohol, patients who've never drank and patients who drink in excess have higher stroke rates than people who have 1 or 2 ounces of alcohol a day. Statistically, we find that we're not quite sure. That means that if you don't drink, you should go out and start drinking. That's not what I'm saying. But people who do have 1 or 2 glasses of alcohol per day do have lower heart disease and stroke rates. If you have elevated cholesterol, it should be lower, however you're going to achieve that. And if you're a couch potato, your risk of stroke is higher, your risk of heart disease is higher. But interestingly, as Dr. Gazzelli may speak about today, your risk of developing dementia is higher, because we think half of dementia is related to vascular disease of the brain. In all the preventative strategies we've talked about, in addition to preventing heart disease and stroke, prevent dementia. 2 others is that if you've had a prior stroke, there's certain things we can do to reduce your risk, which are medications we'll talk about, and then diabetes, that if you actually control your diabetes well or prevent yourself from ever getting it, we think we can lower your risk. So stop smoking if you are. My opinion, cold turkey is the way to go, or meet your wife who won't let you chew tobacco, one of those, I guess. If you have high blood pressure, be religious about your medications, but don't just trust your doctor to measure your blood pressure. Do it yourself. Keep track of it. Own it. Find out what your blood pressure is. Treat it with medications, diet, and exercise so that you can get it down. You can do it. We can do it with meds, but a lot of you can become very proud of yourself that as you lose weight and exercise, you can get off medications entirely. But measure it yourself. Don't take somebody else's word for it. You should limit yourself to 2 ounces a day or less of alcohol. For women, it's 1 ounce per day. There is, this is, I said, a complex function. Too much is too much, too little. I don't know if you should take alcohol if you haven't, but statistically, we know that 1 ounce or 2 of alcohol per day is associated with better vascular health. Of your cholesterol, we always get into these different HDL, LDL things, and we talk. I think a good way to remember this is the bad cholesterol, which is the LDL cholesterol. You've heard about cholesterol ratios, whether, yeah, my cholesterol's high, but my ratio is good. We're pretty much getting away from that now and looking purely at the bad cholesterol level. If you've never had a heart attack, a stroke, anything, you're otherwise healthy, but your serum LDL is above 130, it should be treated. It should be lowered. That's primary prevention. We have children that we're putting on statins now. Isn't that interesting? American Academy of Pediatrics, I'm not sure I got the society name right, but are now recommending that for certain high-risk populations, children, pre-pubertal children will be on statins to lower their cholesterol. We think what happens is if you keep your cholesterol low over many years, the vascular disease never develops. And these two, hypertension and vascular disease, are related. So you can actually prevent yourself from developing hypertensive disease long term, we think. If you've had a stroke or TIA or heart attack, we want to get the LDL under 75. And if your cholesterol was high to begin with, it is nearly impossible to get it that low without medications. Diet and exercise help, and you can lower it somewhat. But if you've had a stroke, we have most of our patients taking statins. They're now off patent, they're generic. There is some side effects I'm sure some will ask about, but they're very important. So what fits your busy schedule? Exercising an hour a day or being dead 24 hours a day? I guess if you're dead, you don't have to plan, so, you know. But the current recommendations are around 20 minutes a day, 5 days a week. And exercise here can include walking. So if you're walking 20 minutes a day, you've done it. That's fantastic. If you want to do more, that's fine. But if you're walking once a week, or if you are disabled and cannot exercise to that level to get your heart rate up, think about ways that one can elevate their heart rate to get your cardiovascular system in tone. Responsible diet, there's lots of different diets out there, but I think the thing that is common among all of the diet therapy is your body mass index and getting your weight down. However you can do that, the diet's working for you. Fad diets are not great because you lose weight and you gain it back. It's getting into a normal body weight and maintaining it that is almost entirely behavioral. We have dietitians that can help, friends who can help, calorie counters that can help. However you do it, the key is to maintain a body weight long term. So learn the warning signs of stroke. If you have weakness, numbness, paralysis of face, arm, or leg that comes and goes, that's a TIA until proven otherwise. If you can't speak suddenly, if you have a sudden loss of balance, difficulty speaking, double vision, or sudden severe headache, these all can be warning signs of a stroke to come. What we'll do, or what you should do at this point, is call 911. I really don't want to bother them. I don't want the paramedics to come in. I don't think the paramedics could actually get in the front door. It's locked. Well, stop listening to the other half of your brain that's saying don't do this. Dial 911. Okay? If it's your loved one, dial 911. If it's you and you can reach the phone, dial 911. Get paramedics there, because we can get you access to stroke treatment within minutes, and time is very important. Are you embarrassed by it if it turns out to be a TIA and you're normal in the ambulance on the way in? Fine, so what? Be embarrassed. The bottom line is that we now know you have a TIA, and we can do things to figure out why you had the TIA and prevent the stroke that's going to happen tomorrow. So we still need you there, okay? What happens if it turns out that it was you slept on your arm funny and your arm was numb, and then you went through all this hullabaloo and went to the hospital and they said, gee, you're fine, sent you home. Oh well, right? It happens all the time, and that's okay. You have to have some false alarms, because the real alarm is the one that we need to treat as a brain attack. We can do things, and I'll close here, open for questions on things to prevent stroke. Because stroke is predominantly ischemic, we can prevent it by making the platelets in your body less sticky. Aspirin, clopidogrel, Agrinox, there's all kinds of drugs that we use for that purpose. They have the risk of causing stomach ulcers and causing bleeding in the body, but if you compare the bleeding risk to the preventative risk, those treat stroke and reduce stroke risk about 25% by themselves. If you have atrial fibrillation, that chaotic contraction of the heart, we want you on blood thinners. Warfarin was the old drug. There's all kinds of new ones that have come out now which are safer and more effective and don't interfere with diet, which is important, that should be prescribed and should be taken long term. And if there's disease in the carotid arteries, we can open that up surgically, put a stent in there, take it out surgically. But in addition, we'll have your blood pressure controlled and your platelets affected. And then weight loss, exercise, blood pressure control long term. Those are all treatments which we can do for secondary stroke prevention. So stop smoking, treat your blood pressure, get your cholesterol down, follow a responsible diet and exercise. I sound like your mother. And remember the stroke warning signs. I'm going to stop here, and we have some time for questions. Remember, this is being recorded, so no personal information. But if you could limit it to one question, and I'll respond, but do use the microphone so that people in the recording can hear you. Yes, sir.
How important are hereditary if your father or your grandfather had a stroke or an embolism or something like that?
It turns out that it's not that important. It becomes relevant only in that if your grandfather, your father, mother, or brother, somebody has high cholesterol, it's relevant. But we want you to get your cholesterol checked anyway. So if you had a brother, sister, whatever, who had stroke and your cholesterol is normal, outside of some very rare familial syndromes of stroke, it tends not to be that important. Now, where it does turn out to be important is in socioeconomic stuff. If dad is huge as his son, you're going to tend to be bigger. So there are those factors that are in the environment that have to be fixed, and that's a hard thing for us to really change.
Warfarin and Coumadin, that's what they use to poison rats. how much history do we have in the use, and how many experiments have we tried?
Well, you're absolutely right. Warfarin is used as a poison for rats because, number one, they eat it for some reason. They like it. And second, what it does is it makes their blood clotting in, rewind. It makes them unable to produce clots, right? So they bleed to death, basically, usually in your wall, right? And then you got to get this dead rat out of your house, right? So we don't really use warfarin much more anymore because it actually it harms other pets, and so it's not really used much. It's used in some cases. Why did we use it in humans? Well, we knew that if you actually thin blood enough for patients with atrial fibrillation, it reduces the risk of stroke dramatically. So if you have atrial fibrillation and you have a few risk factors, like say you have high blood pressure and atrial fibrillation, your risk of having a stroke every year is 6%. If you take warfarin, it's less than 1%. So it's a 6-fold reduction in risk of stroke, which is quite, and these are big strokes and bad strokes. So that's why we prescribe it. The problem with warfarin is it interferes with vitamin K, a vitamin you get in your diet, and you have to have just enough warfarin so that you're anticoagulated, but not too much so you'll bleed to death, right? The newer drugs don't work through that pathway, but they have, when compared to warfarin, are more effective and don't interfere with diet. And they don't require blood draws to measure its effect. So if you're on warfarin and you're doing fine, stay with it. If you have AFib and you are having trouble managing your anticoagulation status, consider switching. Most of the insurers now pay for these drugs, and they truly are a big innovation for our treatment.
I've seen some new federal guidelines regarding blood pressure standards for people over 60. It says 150 over 90.
Yeah.
No more than that, and you're okay. How does that fit in with your ideas?
I think that I just beg to differ, and it's interesting because those society recommendations that came out were quite heavily criticized because we think it was sending the wrong message. What they're saying is the evidence basis for this is that 150 over 90 clearly is bad. Above that is clearly bad. I have no question about that. I have many patients who come into my clinic who have had a small vessel stroke in the brain, which we think is principally caused by hypertension, whose blood pressures have been typically 140, 145 systolic. And we almost never see that disease in people who are lower. So that's anecdotal, fair enough. If you look at clinical trials where each time we randomize patients to a little lower blood pressure target than a high one, every time we've done these trials, the lower the blood pressure, the better. Now, people wouldn't do a randomized trial with 150 systolic, that's considered hypertension. So those current recommendations came out as a basis of, hey, you guys haven't done enough science on this, but I can tell you that your blood vessels are healthier the lower your pressure. And the lower you get, the only risk of getting too low is if you stand up, you'll faint and break a hip. That's too low, right? But we have not established that a low blood pressure that we've induced in patients is harmful. So we like it lower. One of my stroke neurologist colleagues says, I want to be 120 over 70 for my whole life. And he's done that pretty well. It gets hard to get that low enough blood pressure once your vessels get older and aged. But 150 over 90 is something we consider way too high.
There are some dissident MDs who disagree about cholesterol. Could you address yourself to that? They say the problem is inflammation and that cholesterol is actually a natural thing that's good for you.
Yeah, cholesterol is very important. I mean, one of the major substances in our brain that make up our nerve cell membranes is beta cholesterol. It is a compound that is used in the body tissues. We do know that, in fact, what you're saying is absolutely right. The problem with these atherosclerotic blood vessels is they're inflamed. They're clearly inflammatory. Those myocytes I showed that were glomming onto the vessel, that's inflammation. And we know that actually cholesterol, it gets incorporated into these atheromas during inflammation. So it may not be that the cholesterol is the bad actor. It could be an innocent bystander. But we do know if you lower the cholesterol level, the degree of atheroma deposition decreases. So what we do for somebody who has narrowing of their carotid artery that's moderate to severe, but they've never had a stroke, if we keep their cholesterol normal, they don't have strokes, they never need a surgery on their carotid. It doesn't get worse. But if you don't give them lower cholesterol agents, their artery will get progressively more narrowed and will need a surgery. So they're all overlapping, and the way you can interact, because we don't have good anti-inflammatory agents, is to lower cholesterol.
Okay, AFib is bad. What about non-AFib irregularities in your heartbeat?
If it's truly not AFib, it is fine. So a lot of people have PVCs, these little, your heart beats a couple extra beats, or you feel like your heart stopped for 2 beats. I sure hope that's not bad, because I have it all the time. And you get it more with coffee, like if you drink coffee and you get a little bit of a run of rapid heart rate. All those things are considered benign. If it's AFib, though, which you really have to document with an electrocardiogram, a good cardiologist can listen to your heart and say it's AFib, but electrocardiograms are simple, easy. What we're finding now is that there's a whole population of people who've had a stroke. We didn't know why they had a stroke. And then we measure their electrocardiogram in the emergency room, it's fine. We have them on telemetry, so we look at every heartbeat for the first 3 days that they're in the hospital, and it's totally normal. If you hook them up to a heart monitor that they wear for 2 weeks, 1/5 of those patients will develop AFib. And then what they'll do is they'll go in and out of AFib. I had this one guy, he's a multi-marathoner. He's over age 70, he's won 5 marathons in the United States in his age group. And he came in with a stroke and had, couldn't tell why he had it. Said, do you have any irregularity to your heart? This is a guy who's, totally in tune with his body, right? And he said, my heart's fine. My heart rate sits at about 50 or 40 when I'm relaxed, which is good for someone who's a big runner. And we hooked him up to the machine at home, and it overloaded its recordings in the first day because his heartbeat was going so fast. And his heart rate would get up to 220 while he was just sitting watching TV. Had no knowledge of it at all. He couldn't tell. He just felt fine. And so then he was placed on blood thinners and has not had another stroke, thank God. But now I've seen 5 other. I saw a woman in her 70s, also an ultra-marathoner. And the character of this, it looks like their heart rates are really, really slow at baseline, and they have big dilated right atriums and left atriums. So going in and out of atrial fibrillation is as bad as having chronic atrial fibrillation at the same risk. And so if you have an irregular heartbeat, you should find out what it is. And that can be done with one of these monitors that you wear for a few days. They're really easy to use, and they truly can be preventative for stroke.
Dr. Smith, how does diabetes increase your chance of getting a stroke?
So how does diabetes increase your risk of stroke? Diabetes is a disorder that affects microvessels throughout your body. So the arteries that run to your eye, to the retina, the arteries that run to your kidneys, the arteries that actually feed the nerve fibers out into your limbs are small enough. That size of artery, the ones that get impaired by diabetes. It's something related to both the absolute blood sugar level, but also other complex factors that I don't think are fully understood that make those small blood vessels close off. And they happen with some regularity, so they're closing off all the time while you're diabetic. So a person will develop neuropathy, numbness of their fingers and toes, because they cause damage to the nerve fibers going to the limbs. It'll cause damage to the kidney itself by causing small areas of low blood flow to the kidney, so the kidney dies and you develop renal failure. For the arteries of the neck and the arteries inside the brain, the arteries are big enough they actually need a blood supply. So that your carotid artery actually doesn't get its oxygen from the blood that's flowing through it. It actually has a network of blood vessels inside the wall of it. Those vessels are the small-sized arteries that diabetes gets to. So when I showed you that one diagram of an atheroma forming, that there was some injury to the surface of the vessel, we think that some of those are related to diabetes, where it causes low blood flow to the vessel wall dies, it inflames, like you're talking about, cholesterol comes in, the atheroma forms. So diabetics have a lot of atherosclerosis. Keeping your blood sugar lower reduces the rate of development of atherosclerosis. So that's a long answer to the question, but the prevention of diabetes itself is the biggest teaching point. If you have diabetes, then it's getting your blood sugar in normal as much as possible, especially if you can do it through weight loss exercise. That seems to be the best way to treat it, other than insulin and other things.
Do you advise a half a baby aspirin a day?
Not for people who are healthy. So if you have no risk factors, so 45-year-old person who's healthy has a higher risk of an intracerebral hemorrhage taking an aspirin a day than not, actually. And that's in part because the risk of an intracerebral hemorrhage is really low to begin with. So all you're doing is adding the risk of bleeding and no benefit. But as you start getting risk factors, hypertension, diabetes, if you're a smoker, for example, then aspirin, the downside of aspirin is starting to be traded off by its prevention. So it really depends upon risk factor presence. It's also one of those things that's studied mostly in men and not in women. No surprise because of how studies have been done. But so do not take an aspirin if you have no risk factors. If you have risk factors, really talk with your doctor about whether it's worth it or not.
What are the chances? I was taking baby aspirin one a day, but I also have cataract. And then my ophthalmology said that I better stop the baby.
Where are you? I'm sorry, I can hear the voice, but oh, back there, okay. Yes, so that's an example. So some patients can have retinal bleeding from aspirin. Aspirin stops the platelets, so that means that you can bleed a little bit. And if you have retinopathy or retinal disease, which is one of the things that diabetes can do, aspirin can make you have hemorrhages into the eye. And that's obviously not something you want. So it's a great example of where aspirin's not right for everybody, because it does have some risk. I'm going to stop. Thank you for coming, and I'll be up here for a few more minutes too if you have some other questions. Thank you.